Hello, so this is part 2 of the 3-part congenital heart disease talk. So if you would like to see any of the other lectures that are being produced by my colleagues, do click on any of the other videos of this channel. Make sure you check out part 3 of this video afterwards, and if you haven't seen part 1 yet, check that out first and come back. And please like and subscribe to the Medics.Academy YouTube channel to get notified about future videos as our content is consistently updated. And if you're a medical student, please sign up for the free SDocs program, which you can find out about in the link in the description below. So now on to part 2 of the congenital heart disease talk, which is on right to left shunts. So there are 5 different kinds of right to left shunts. And an easy way of remembering them is just to use the 5 T's. So you have Tetralogy of Fallot, transposition of the great arteries, which are the 2 most common right to left shunts. And then the other 3 are, you can think of that for a second, and they are truncus, total anomalous pulmonary venous return, and tricuspid atresia. But for this lecture, we're going to be mainly focusing on the first 2, tetralogy and transposition, because those are way more common than the other ones. So what is a right to left shunt? So a right to left shunt is basically when you have blood flowing across a defect from the right side of the heart to the left side of the heart. And because it's flowing from the right side to the left side, it's not being oxygenated. So it's not going through the lungs, through the pulmonary arteries to get oxygen. So you basically have deoxygenated blood flowing to the periphery or to the body. And this is what will cause a cyanotic or a blue baby that from birth will be blue and will be breathless right away. And so this is much more of a medical emergency than a left to right shunt. And these are the babies that will die without immediate intervention. So the first example of a right to left shunt is transposition of the great arteries. So in a regular transposition of the great arteries, or TGA for short, you have 2 separate systems that form. So the vena cava, which is here, your SVC and your IVC, they connect directly to the aorta with no oxygenation from the lungs. So that causes deoxygenated blood to flow to the entire body. And then your pulmonary veins connect to your pulmonary artery with no access to your body. So your blood is being oxygenated, but that's not connecting to your body. And the blood that is going to your body is not getting any oxygen. So this is often diagnosed prenatally due to fetal screening, so that you're able to intervene as soon as the baby is born. So to diagnose a transposition of the great arteries, you would use an echo and try to diagnose it for the 20-week fetal anomaly screen. And on echo, what you tend to see is you see that the 2 vessels, so the AO is aorta and the PT is the pulmonary trunk, and those 2 vessels will be parallel to each other rather than crossing, which is what normally happens. And transposition of the great arteries is associated with mothers with diabetes. So this is not gestational diabetes, but diabetes before you're pregnant. So in order to manage a baby with a transposition of the great arteries, in order for them to even survive before you intervene, they usually have a large ASD or a patent ductus arteriosus. So just in case, the immediate treatment for any baby diagnosed with a TGA is to give them prostaglandins to make sure that their duct stays open, because that duct is the only thing that's causing oxygenated blood to get to their body. And then your eventual treatment would be something called an arterial switch procedure, which is an operation that would occur within the first couple days of life, where, as you can see from photo 2 and 3, you essentially cut off the bottom of the pulmonary trunk and the aorta, and you switch them with each other. So the next really common right to left shunt is a tetralogy of Fallot. It's called a tetralogy because there's 4 main features. And so the question is, which of the following is not one of the 4 characteristics of a tetralogy? And the answer is B, coarctation of the aorta. And that's because the 4 main features of a tetralogy is a VSD, a pulmonary stenosis, right ventricular hypertrophy, and an aorta overriding the VSD. So the presentation of a tetralogy of Fallot is that the stenosis of the pulmonary trunk causes right to left flow over the ventricular septal defect. So right here is the right side of the heart, and here is the left side of the heart. And because of the stenosis of the pulmonary artery, this causes there to be increased pressure on the right side versus the left side, which will cause deoxygenated blood flowing directly to the left side of the heart and to the body. So the severity of this disease is directly dependent on how stenosed this pulmonary trunk is. So what can happen is that because of that, you'll have a spectrum of Tetralogy of Fallot. So you'll have some babies that have a really, really significant degree of stenosis that will be cyanotic at birth, or you'll have some babies that will have these things called cyanotic spells, where during crying or feeding, they'll basically turn blue. And that's because those times cause them to have increased work of the heart, which would then cause increased deoxygenated blood flowing, which would then make them turn blue. And Tetralogy of Fallot is associated with DeGeorge syndrome and also fetal alcohol syndrome. And this is a photo of what like a cyanotic or a TET spell would look like. And so the question is, what improves TET spells, which is again a cyanotic spell caused by tetralogy? And the answer is B, squatting. And the reason why is because it increases your systemic vascular resistance, which then causes less blood to flow from the right side of the heart to the left side of the heart. So you get less deoxygenated blood flowing to the body. So to diagnose the Tetralogy of Fallot, the definitive diagnosis would be using an echo. And this is another form of congenital heart disease, which is often diagnosed prenatally due to all the screening that should occur prenatally. So at the 20-week fetal anomaly screen, it should be ideally diagnosed then. And also on a chest X-ray, these patients would have a boot-shaped heart, which you can see in the image on the screen. For treatment, it's going to be a surgical treatment. And there's two different ways that you can treat tetralogy. You can either repair the pulmonary stenosis and patch the VSD, or you can do both stages of surgery at the same time and do a definitive repair right away. And so the different hospitals will do different forms of management. So it depends on what your local hospital does. And so then next I'm going to go through coarctation, and then the last part will be just the cases. So coarctation of the aorta is when you have a narrowing of the aorta, usually distal to the three great vessels coming off of it. So as you can see in this picture, it's after you have your three first branches. And what it presents with is hypertension in the upper extremities and hypotension in the lower extremities. And another sign that you can have is what's called radiofemoral delay, just because again of that delay of your femoral pulse versus your radial pulse. And you can also have symptoms of headache and leg fatigue. Headache is just because you're having so much blood going to your upper part of your body because of that narrowing that's distal to your vessels that lead to your head and neck. And leg fatigue is because your lower half of your body isn't getting enough blood, so you get fatigue. And this is associated with Turner syndrome. So to diagnose, you would again use an echo for definitive diagnosis, but in older patients that might have their coarctation missed, they would develop something called rib notching, which you would see on a chest X-ray. And that's just because you get increased intercostal vessels that start to bulge, and that's just to create another pathway from your top part of your aorta to your bottom half of your body. So the way you would treat a coarctation of the aorta is to repair it. So it can be done via catheter if possible, or it might need open surgery as well. But it's most commonly done via a catheter, which you can see kind of in the picture at the bottom. And that is the end of part 2 of the congenital heart disease talk.